You're halfway through your Nclex when this scenario hits your screen, and every answer choice looks terrifyingly correct. A HIPAA violation just happened. Multiple witnesses. No supervisor around? Choose wrong? Your nursing license dies before you even get it. Here's what's crushing nursing students. This isn't about knowing HIPAA rules. It's about cracking the Nclex's twisted logic that contradicts everything you learned in clinical settings. By the end, you'll think like the test makers think. And you'll understand why your correct clinical judgment is actually the wrong Nclex answer. But first, let me show you the one detail in this scenario that changes everything. This is Clinic RN. Let's break down question 1. The nurse is working on a telemetry unit, caring for a client recently admitted for atrial fibrillation. So let's have a look at the patient's information. Patient name, Mr. Anthony Reed. Age, 58. Diagnosis, atrial fibrillation with rapid ventricular response. Admission date, June 2, 2025. Room, 216. Advance directive, none on file. Family notified of admission? Yes. Wife and daughter listed as emergency contacts. Now that we know the patient's information, let's have a look at his vital signs. Pulse, 112 beats per minute, irregular. Blood pressure, 138 over 84 millimeters of mercury. Respiratory rate, 18 per minute. Temperature, 98.9 degrees Fahrenheit, or 37.2 Celsius. Oxygen saturation, 96% on room air. And finally, the nursing notes, which read, Telemetry unit. While administering evening medications, overheard unit secretary discussion about Mr. Reed's diagnosis and admission details with another hospital employee in the hallway within earshot of visitors and staff. Secretary stated, he came in with a heart arrhythmia and almost passed out. He's in room 216. The nurse reminded the secretary of HIPAA policy. Secretary replied, but it's just Julie from radiology. She's his cousin. All right, now that we've covered the various data points, let's have a look at the question. You recognize that a staff member has inappropriately disclosed protected health information. What is the nurse's primary legal and ethical obligation in this situation? 1. Notify the family that their information was disclosed. 2. Report the breach to the nursing supervisor. 3. Reassign the unit secretary for the shift. 4. Apologize to visitors who overheard. What's your answer? Let's go one by one. Option 1. Notify the family. Sounds responsible, right? But that's not actually within the nurse's scope. Only the hospital's privacy officer or compliance team can notify a patient or their family about a data breach. They handle it formally, with documentation, investigation, and timelines that comply with HIPAA. Option 2. Report the breach to the nursing supervisor. That's your correct answer. Nurses are legally obligated to report any suspected or confirmed breach of PHI to the appropriate chain of command, usually your nursing supervisor or privacy officer. Even if the breach was unintentional or seemed minor, it still has to be documented and reviewed. Option 3. Reassign the secretary for the shift. Nope, the nurse has no authority to reassign or discipline staff. That's the manager's job once the report is made. Option 4. Apologize to the visitors who overheard. It might feel polite, but it's risky. Apologizing can actually make the breach worse by confirming that the details were true. That's more exposure. And more liability. By the way, if you want to practice these same style questions, check out the Clinique RN Q-Bank. It's got everything you need to level up your prep. AI feedback system that explains every answer in plain English. CAT mode so you can train under real Nclex conditions. And a summary sheet to help you review and track your progress after every session. It's like having your own personal Nclex coach in your pocket. You can sign up for free using the Clinique RN link in the description. and start practicing right after this video. So, to the second question. We know the secretary's hallway conversation broke some boundaries, but now let's go deeper. What parts of that chat were actually HIPAA violations, and which ones were just education moments? You've got 4 chances to test your instincts. Think you can spot all the right ones? Let's find out. We'll go through each line from that overheard exchange. I'll give you a second to decide before I reveal the correct response and why. Row 1. Mentioning diagnosis to a non-care team member in the hallway. First one. The secretary says he came in with a heart arrhythmia and almost passed out. She's saying this to someone who's not part of the care team. What's your call? HIPAA violation, staff education, or no concern? The correct answer is HIPAA violation. Now, the rationale. Protected health information, or PHI, was shared in a non-secure area with someone not directly involved in the patient's care. Even if that person works in the hospital, their job title or relationship doesn't grant them access. Row 2, mentioning the client's room number and symptoms. Next, she adds, he's in room 216. Room number plus diagnosis? Sounds innocent, but what do you think? The correct answer is HIPAA violation. Rationale. Disclosing both the diagnosis and the exact room location links the medical condition to an identifiable person. That breaks the identifiable health information rule under HIPAA. Row 3, saying she's a cousin, not a stranger. Then she says, it's fine, she's his cousin. What do you think? Staff education need is the correct answer. Rationale? This reflects a common but risky misunderstanding that family connections automatically mean access. They don't. Unless the patient gives permission, even relatives need authorization to receive details. This one's not a violation, but definitely a training opportunity. Oh, row 4. Nurse redirected staff and reminded them of the policy. Last one. The nurse immediately stepped in and reminded her coworker of HIPAA policy. HIPAA violation, education, or no concern? Correct answer, no concern. Now the rationale. The nurse acted professionally and ethically by intervening. Exactly what should happen in real life. No breach here, just accountability in action. Now to question 3. You're passing meds when you overhear 2 hospital employees talking just outside the patient rooms. At first, it sounds harmless, but then your instincts kick in. Something about what they're saying feels off. The question is, can you spot the cues that point to a potential confidentiality breach? Let's see how sharp your HIPAA radar really is. Here are 6 details from that overheard moment. Take a second after each one and decide, is it relevant to a potential breach or not? Select all that apply. 1. The secretary shared the client's diagnosis in a public space. What do you think, breach or not? The correct answer? That's a HIPAA violation. Rationale. Discussing a client's diagnosis, like heart arrhythmia, in a non-private area is unauthorized disclosure of protected health information, or PHI. Intent doesn't matter. Location does. 2. The conversation occurred within earshot of visitors. Breach or not? Yes, relevant to a potential breach. Rationale? Even if the conversation isn't directed at others, it still exposes PHI to people who shouldn't hear it. HIPAA calls this incidental exposure. And it's still a violation if precautions weren't taken. 3. The client is in an intermediate care room. Sounds clinical, but is it relevant? Nope, not related to the breach. Rationale? The type of hospital room doesn't identify the patient or disclose private information. It's just background context. 4. The secretary stated the staff member was a cousin. What do you think? Does that matter? Yes, this contributes to the breach. Rationale? Family ties don't equal permission. Even relatives need explicit consent from the patient to receive medical information. The statement shows a misunderstanding of HIPAA policy, a red flag for staff education. Number 5. The nurse was administering evening medications. Does that have anything to do with the breach? No concern. Rationale. This is just environmental context. It doesn't relate to privacy or disclosure of PHI. Number 6. The room number and diagnosis were disclosed. Last one. Think carefully. Yes, major HIPAA violation. Rationale. Linking a diagnosis with a specific room or location makes the patient identifiable. That's in direct breach of HIPAA's minimum necessary rule. If someone not involved in care can piece together who it is, it's a violation. So the correct answers are 1. Share the diagnosis publicly. 2. Conversation within earshot of visitors. And 4. Mention the cousin. 6. Shared the room number and diagnosis. The rest? Not breaches. Question 4. So you did everything right. You overheard a privacy breach, reported it to your charge nurse, and now management is stepping in. The nurse manager is requesting written statements from everyone involved, and the secretary is asking if she should apologize to the client directly. The incident's already logged in the compliance system, and the client hasn't been told yet. What happens next? Let's figure it out together. Based on what you've seen so far, let's answer 2 key questions. 1. What kind of breach was this? 2. What should the nurse do next? I'll give you a moment after each to lock in your answer. First question. The breach occurred because of 1. Intentional client harm. 2. Gossip between nurses. 3. Unintentional disclosure of protected health information. 4. Visitor complaint. Think about what actually happened. Correct answer, unintentional disclosure of PHI. That's personal health information. Now the rationale. The secretary didn't mean harm, but intent doesn't erase the breach. Sharing private details in a public space without authorization is still a HIPAA violation, even if accidental. It's what's called an unintentional disclosure. And yes, it must still be reported and documented. Now part 2. What should the nurse do next? 1. Ask the client to file a HIPAA complaint. 2. Provide staff with a privacy policy brochure. 3. Follow the institution's procedure and submit written documentation. 4. Contact the cousin from radiology to clarify her intent. Correct answer. Follow institutional procedure and submit written documentation. Rationale. The nurse's responsibility ends with proper reporting, not fixing or confronting. Submitting a written statement ensures there's a formal record and triggers a compliance review. It also protects the nurse by showing accountability. Let's look at why the others don't fit. Intentional harm. There was no sign of malice. Calling it intentional would exaggerate the event. Gossip between nurses. This wasn't casual chatter. It was the sharing of medical info, which makes it a privacy breach. Asking the client to file a complaint. That's not your role. Only compliance or risk management decides if and when to inform the patient. Contacting the cousin. Doing that could actually confirm the client's info, creating a second violation. All right, last but one challenge. You've reported the breach. The compliance team's on it, and everyone's giving written statements. Let's see if you can spot why this breach really happened and what the nurse's next 2 actions should be. Let's play fill in the blanks. The root issue in this scenario is dash. Actions the nurse should take are dash and dash. Here are your options to drag in. Client's overreaction, poor communication with the family, staff's misunderstanding of HIPAA. Action choices. Reinforce the importance of HIPAA with all unit staff. Have the cousin sign a consent form after the fact. Tell the secretary to avoid speaking in hallways. Document and submit an internal report. Let's start with the root issue. What's the real cause of this whole situation? The correct answer is staff's misunderstanding of HIPAA. Rationale. This secretary honestly thought sharing details with a cousin was okay. That's not malice, that's a misunderstanding. So this breach came from a knowledge gap, not an intent to harm. Now, first action. What's the most important step the nurse should take? Correct answer? Reinforce the importance of HIPAA with all unit staff. Rationale. Education is the immediate fix. It prevents repeat violations by reminding staff what can and can't be shared, especially in open areas. Think of it as a mini in-service moment. Next blank. What's the nurse's second action? Correct answer, document and submit an internal report. Rationale, every potential HIPAA breach, even if minor or unintentional, must be formally logged. Documentation triggers the compliance process and protects everyone involved, including the nurse. Let's clear up why the other choices don't fit. Apologize on behalf of the secretary. That could confirm the breach to the client, which only compliance is allowed to do. Have the cousin sign a consent form after the fact. Consent must be given before disclosure, not after. Retroactive approval doesn't count. Tell the secretary to avoid speaking in hallways. That's a good reminder, but it doesn't fix the core issue. It's a misunderstanding of HIPAA rules. All right, nurses, you've handled the breach, filed your report, and the compliance teams are on it. But here's the real test. Were the follow-up actions handled ethically? For each action, decide whether it was appropriate, needs follow-up, or requires clarification. You'll get a moment to think before I reveal the answer. Let's go. First up, the nurse submitted a written account of the incident. What do you think? Was that the right thing to do? The correct answer is appropriate ethical response. Rationale. This fulfills the nurse's legal and ethical duty to document the event per policy. It ensures transparency, accountability, and supports future audits or investigations. Next, the unit secretary privately apologized to the client. Sounds sincere, but is it appropriate? The correct answer needs follow-up and requires clarification. Rationale. While it might seem like the right thing emotionally, it's not appropriate legally. Unauthorized staff shouldn't approach clients about breaches. That can confirm details and increase liability. Any client communication must go through the compliance office or privacy officer. Third, privacy breach reported to the compliance office. Simple one. What's your answer? Appropriate ethical response. Rationale. Reporting to compliance is the gold standard. They handle investigations, coordinate notifications, and provide legal protection for both patient and staff. Next, the cousin was told not to discuss patient information next time. Sounds like a quick fix, but is it ethical or effective? Correct answer. needs follow-up, and requires clarification. Rationale? That's an informal response. It doesn't educate, document, or enforce policy. The nurse should instead escalate through official training and compliance procedures, not casual conversation. Last one, the client was not notified about the incident. Think carefully. What does HIPAA say about that? Oh, correct answer. Needs follow-up and requires clarification. Rationale: HIPAA requires that clients be formally notified if their PHI was compromised. If that hasn't happened yet, it's an ongoing compliance gap that must be addressed by the privacy officer. All right, nurses, let's put your critical thinking to the test. You've got a patient with anuria. They're not making urine, and the provider prescribes mannitol. Here's the question. What's the very first thing you should monitor when this medication is started? Is it monitor for a decrease in blood pressure? 2. Assess for signs of pulmonary edema? 3. Check for increased urine output? 4. Observe for hypokalemia symptoms. Take a moment. What would you do first? Correct answer. Check for increased urine output. The rationale? Mannitol is an osmotic diuretic, which means its job is to pull water into the renal tubules and get that urine flowing. The very first indicator that it's working is, you guessed it, an increase in urine output. If that doesn't happen, it's a sign the kidneys aren't responding, and the provider needs to be notified right away. Let's quickly go through the others. Blood pressure. Mannitol doesn't drop BP significantly. It's not a vasodilator or antihypertensive. Pulmonary edema. Possible later if the patient already has heart issues, but not your immediate concern when starting therapy. Hypokalemia. Mannitol doesn't cause big electrolyte losses like loop diuretics. It mainly affects fluid shifts, not sodium or potassium transport. Now question 8. This one's a life or death kind of question. A 55-year-old patient with acute promyelocytic leukemia suddenly shows signs of disseminated intravascular coagulation. The bleeding won't stop. Platelets are dropping, and you've got 4 possible interventions on the table. The question is, what's your priority right now? Which intervention should the nurse prioritize to reduce the risk in this patient? 1. Administer fresh frozen plasma. 2. Encourage oral hydration. 3. Provide supplemental oxygen. 4. Administer vitamin K. Think it through. What's going to make the biggest difference in disseminated intravascular coagulation? Correct answer: administer fresh frozen plasma. Rationale: disseminated intravascular coagulation burns through your clotting factors fast. Fresh frozen plasma, FFP, directly replaces those depleted factors, stabilizing coagulation and reducing the risk of hemorrhage. It's not optional, it's life-saving. Let's break down why the others aren't priorities. Oral hydration. Sure, fluids help overall stability, but it doesn't fix the real problem. The blood's lost its ability to clot. Oxygen therapy. Good supportive care, but it doesn't touch the coagulation issue. Vitamin K. This helps with clotting factor synthesis, but that process takes time. Disseminated intravascular coagulation needs immediate replacement, not slow rebuilding. That's why FFP comes first. It gives your patient the missing tools their body can't make fast enough. Let's take a quick look under the hood. DIC, disseminated intravascular coagulation, is a chaotic, two-sided condition. The body forms tiny clots everywhere, using up all the platelets and clotting factors. Then, when you actually need to clot, there's nothing left, and the patient starts bleeding from IV sites, gums, and surgical lines. The result? thrombosis and hemorrhage at the same time. That's why FFP is the priority. It stops the bleeding spiral by replenishing the depleted clotting factors immediately. Here's how you remember it. FFP for DIC, the mnemonic. F, fresh frozen plasma, means it replaces clotting factors. F, factor replacement, means stabilizes coagulation. P, platelet transfusion if needed, means it prevents bleeding. Say it with me. When it's DIC, think FFP. For question 9, picture this. A 32-year-old just came in from a major car accident. Labs are back. Hemoglobin, 6.5 grams per deciliter. That's dangerously low. The question is, what's your priority right now? Let's see if you'd make the right move in this emergency. Which intervention should the nurse prioritize to reduce risk in this client? 1. Prepare for an immediate blood transfusion. 2. Administer oxygen at 2 liters per minute via nasal cannula. 3. Start IV fluids with normal saline. 4. Initiate continuous telemetry monitoring. What's the first thing you do for a trauma patient with a hemoglobin level this low? Correct answer? Prepare for an immediate blood transfusion. Rationale: a hemoglobin of 6.5 grams per deciliter means the blood can't carry enough oxygen to vital organs. This patient isn't just anemic, they're in acute blood loss, and every minute counts. The fastest way to restore oxygen delivery? Transfuse red blood cells. Let's break it down. Oxygen therapy, 2 liters per minute. That's supportive care. But oxygen can't help if there aren't enough red cells to carry it. IV fluids, normal saline, helps volume a little, but it dilutes blood further if you don't replace RBCs. Telemetry, monitoring helps you see instability, but it doesn't fix the cause. That's why blood transfusion takes priority. It directly solves the life-threatening issue, severe anemia. Here's the physiology behind it. Hemoglobin carries oxygen. When levels drop below 7 grams per deciliter, the body can't deliver enough oxygen to tissues, no matter how fast or strong the heart beats. So, the goal of nursing care here is to restore oxygen carrying capacity quickly. Transfusing packed red blood cells increases oxygen delivery, prevents organ hypoxia, and stabilizes perfusion, especially post-trauma. All right, nurses, for the final question, I have this quick scenario for you. You're caring for a patient with a femur fracture placed in balanced suspension traction. The student nurse makes a few comments while doing rounds. One of them's wrong. Let's see if you can spot which one needs correction. Which statement by the student nurse requires correction? 1. The traction setup should allow some movement without disrupting alignment. 2. The traction can be maintained even while repositioning the client. 3. This type of traction requires the client to remain completely flat in bed. 4. This traction uses a pulley system to maintain a consistent line of pull. Take a second. What sounds off to you? Correct answer: this type of traction requires the client to remain completely flat in bed. Now the rationale. That statement is not true. And it shows a misunderstanding of how balanced suspension traction actually works. The whole point of this traction system is that it moves with the client, maintaining alignment while still allowing limited repositioning. Let's look at each statement. 2. Number 1 is correct. The system is dynamic. It balances counterweights and pulleys so the leg can move slightly without losing traction. 2 is also correct. The setup allows you to reposition the patient or raise the head of the bed slightly. Traction stays constant. Number 3 is incorrect. The client does not have to lie completely flat. That's actually unsafe. It increases the risk of skin breakdown and pneumonia. Number 4 is correct. The entire system runs on ropes and pulleys that maintain continuous pull without needing manual readjustment. Let's make this visual. In balanced suspension traction, the patient's leg is supported by slings and a pulley. The weights provide a constant, balanced pull, keeping the femur aligned while still allowing movement. Think of it like a floating system. If the client shifts, the pulleys adjust automatically to maintain the same line of force. Nurses can safely elevate the head of the bed up to about 20 to 30 degrees, reposition slightly for comfort, perform skincare without removing weights. But never release the traction or remove weights unless ordered. Here's how to remember it. Balance. B. Bed elevation allowed. A. Alignment maintained during movement. L. Limbs supported continuously. A. Adjunct pulleys used. B. No manual traction needed. C. Counter traction via weights. E. Engineered for femur fractures. Hey, future nurse, you made it to the end, which means you're serious about this. So go ahead and like this video, subscribe, and turn on notifications, because every week we turn nursing concepts into real-world confidence. I also want to hear from you. Plan a tag. What's one nursing topic you want us to break down next? And don't forget, you can sign up free at clinicrn.com to get bonus questions, study guides, and tips that aren't on YouTube. Let's grow together. Study smart.